Welcome to Real Health with me, Karl Henry. Folks, what's the difference between type 1 and type 2 diabetes? Can type 2 diabetes really be put into remission? How do you spot prediabetes before it becomes something more serious? Well, specialist registrar in endocrinology and diabetes, Dr Sean Maher, is here to break down the facts, from symptoms and prevention to the latest treatments and lifestyle strategies. Dr Maher, welcome to the show. How are you?
I'm good, thanks for having me.
So, tell us about life. You're in Drogheda doing your rotation now, aren't you?
Yeah, so I'm doing my general internal medicine year in Drogheda this year. Yeah, I just finished up in James's where I was doing endocrinology.
Amazing. How are you finding Drogheda?
It's great, yeah. It's busy, but I'm on a great team that's quite supportive, so that's good.
And was this a role, a job, a career you always wanted to get into?
Yeah, definitely. I think I've worked in diabetes for the last 2 or 3 years, and before that I worked in that as a more junior level as well, and I had some really great mentors who kind of inspired me to get into the field. So it's something I wanted to do for a while.
Chat to me about the prevalence of it. It's a really easy place to start in terms of, but for type 1 and type 2.
Yeah.
How much are we seeing? Is it on the up? Is it on the down? What's the general kind of vibe in Ireland?
So we actually don't know the exact numbers in Ireland because we don't have a diabetes registry.
At all? No.
Yeah, but there is work ongoing for that at the moment. So we base the prevalence kind of off Scotland and their registry there. So roughly there's about 300,000 people living with diabetes in Ireland, and 90% of that is type 2 diabetes. Okay. And about 10% will be type 1, but we don't actually know exactly.
Wow.
Yeah.
Wow, okay. And what between type 1 and type 2, what's the difference? Because it's one of the reasons we wanted to bring you in to do this episode. I think it's really important. I think a lot of people don't know the difference between the two of them. Mm-hmm. And like on this show, we bring people in, we make it really simple, and we explain things really simply to give people, to upskill them, I suppose. And the difference between type 1 and type 2.
So I think to answer that question, you probably have to define what diabetes is in general. So diabetes in a very simple way is a lifelong condition that's characterized by a lack or a deficiency of insulin that leads to high blood sugars. And then type 1 diabetes is an autoimmune condition where for some reason your body produces cells against your pancreas, the beta cells in your pancreas that produce insulin, and you have an absolute deficiency of insulin in type 1 diabetes. So people with type 1 diabetes need insulin as their treatment. And traditionally that was thought of as the diabetes that you develop earlier on in life, but actually you can develop type 1 diabetes at any point in your life. Oh, wow. And then type 2 diabetes is more like a relative deficiency in insulin. So over time, your pancreas is having to work harder to produce more insulin to overcome that resistance. And then over time, it becomes tired and you become deficient and develop diabetes. So it's a relative deficiency. But I think it's also important to mention that there are other types of diabetes besides type 1 and type 2 diabetes as well.
Okay, tell me more. Good.
So there are, rare causes of diabetes. So genetic causes such as monogenic or MODY as another type of diabetes. There's just rare causes, but it's important to know about them. And then also you can develop diabetes from steroids. So you can have steroid-induced diabetes. You can have diabetes secondary to cystic fibrosis. You can have diabetes due to iron overload as well. So these are rare causes of diabetes, but it's important to know that diabetes is probably more of a spectrum than traditionally, and in teaching we think about 1 and 2, but probably it's actually there's probably an overlay there as well.
I never knew that. In 25 years being in health, I never knew that ever. Yeah. And the steroid one, is that steroids like medicinal steroids as opposed to bodybuilding steroids?
Yeah, so more like steroids that would be used for anti-inflammatory, chest infections, for example. So people that are on repeated courses of steroids can develop steroid-induced diabetes from that. Yeah. And
are we seeing the incidence of it in Scotland anyway? Because with the numbers that they have, is it rising? Is it plateauing? Is it declining?
No, so the rate of diabetes is rising definitely, and we know that it's more common as you get older, and we saw that in the national aging study, the TILDA study. So it's more common as you get older, the development of type 2 diabetes. So aging is a risk factor for developing type 2 diabetes in particular, and we know that there's also quite a strong genetic component to type 2 diabetes that there isn't as such in type 1 diabetes. So there's what we would call modifiable and non-modifiable risk factors for developing type 2 diabetes. So non-modifiable would be things like genetics, ethnicity. It's more common in Asian and Black populations. And then also age, for example. And then modifiable risk factors would be the things like diet, lifestyle.
The stuff people just don't want to do. Generally, the genetic you can do nothing about,
Yeah.
but the modifiable stuff, obviously, weight, fitness,
Yeah.
aging, or how you age, they're all modifiable things that you can improve.
Yeah.
And people, they don't want to do them, generally.
I think it depends. Yeah, I think it's difficult, and I think maybe when people are diagnosed with diabetes, sometimes that's an impetus for change. And there are really good, I think, programs available now, especially with the chronic disease management program. So for people with pre-diabetes, there's the diabetes prevention program, and then for people with diabetes that have been diagnosed or have had diabetes for a while, there's education programs that are offered by the HSE, such as Discover and Desmond.
Because with type 1 and type 2 you can reverse it, and type 1 you can't. Am I right?
Well,
potentially.
So I guess that's a common question we get asked in clinic. Is
we see it advertised around a little bit. There are certain people who advertise around being able to reverse type 2 diabetes.
So type 1 diabetes, as I said, isn't like you have an absolute deficiency in insulin. Your pancreas isn't producing any insulin at all. It's due to these antibodies that attack the pancreas, and so these people need insulin as their treatment. And there's different ways of delivering insulin now. We have pens to inject insulin, which is the traditional way, but also now there's insulin pumps, and there's smart insulin pumps that almost act as like an artificial pancreas that communicate with sensors.
Go on.
Yeah.
Wow.
So technology has developed drastically in the last 5 to 10 years in type 1 diabetes. And then type 2 diabetes is a question about whether it's reversible or not. So I think we get asked that quite commonly, and I think technically the answer is yes. And we know this from the DIRECT trial, which was a randomized control trial in the UK, where people were randomized to receive a very low calorie diet, which is about 800 calories a day for 2 years. And on average, they lost about 10 to 15% of their body weight. And that did lead to a remission of diabetes. But the problem with that study was that the long-term 5-year follow-up, only about 30% of people managed to keep their diabetes in remission.
Which would be in line with kind of diets kind of 3 and 10, keep it off, or
yeah.
Okay.
And so while it's technically possible, it's very difficult to do to live on an 800 calorie diet and to lose 10 to 15% of your body weight, and then to maintain that is even more difficult. So I guess the answer is technically it is possible, but it's probably not sustainable and probably not doable for a lot of people.
How with type 2? So we've established what diabetes is on its own. We've established the fact there are more than just these 2 types that we kind of see all the time in the papers. We've discussed the difference between type 1 and type 2. With type 2, why is it becoming more common worldwide, do you think? Is that down to modifiable risk factors?
No, I think people are living longer, which is part of it. And then I think, definitely, I think we know that there's a rise in obesity and there's a rise in overweight. And then I think the general lifestyle that we're living now is more sedentary than before. And a lot of the foods that we're eating are more processed. So I think it's a mixture of things, but probably a combination of diet, lifestyle, and then also that we're living longer.
And with high blood sugars, then, talk to me about what happens when people have high blood sugars and why that's a problem.
So I might talk about what symptoms people might develop in terms of things to look out for, and then how that might affect and cause some complications. So generally the cardinal symptoms of diabetes that we would be thought about would be polyuria, polydipsia, which means I'm drinking a lot of, I'm very polydipsia as I'm very thirsty, and then polyuria as I'm passing a lot of water.
Oh yeah.
So frequent urination.
If you go to the toilet more than normal for a period of time, go into your GP.
Yeah. So if you're very thirsty, you're passing a lot of water, you're losing weight unintentionally, so weight that you haven't been trying to lose.
It's a good point. That is that is a medical indicator for not just for diabetes, for lots of fairly serious stuff. If you are randomly losing weight, get into your GP. Yeah,
that's definite. I think it can also be in cancer, for example. That would be another red flag that we'd be looking for. But definitely, if you're losing weight unintentionally, and then sometimes you might have things like wounds that are slow to heal. People might get recurrent infections, particularly urinary tract infections, and that might be a sign that potentially you're developing diabetes, and that would be an indicator to go get tested with your GP, because it can be diagnosed with a very simple blood test. and so it's very easy to pick up. And oftentimes type 1 diabetes tends to develop quite rapidly. So people get these, out of, they're feeling fine, and then all of a sudden they get rapid weight loss. They're feeling very tired, they're passing lots of water, they're feeling very thirsty. While type 2 diabetes is tends to be more of like a gradual onset, and you might not have those symptoms until later. And so you might not really have any symptoms, and oftentimes it's picked up incidentally. So that's why it is important to have routine blood tests done as well. And I suppose then you asked me about the complications of diabetes. And so the major things that we would always look at in a clinic when someone comes in is always screening for complications of diabetes. So, we want to manage things like blood pressure and as well. And then we're also looking at smoking and whether someone's smoking or not. Because that, again, a lot of the complications from diabetes are also complications of smoking.
Oh, wow.
And so then looking at things like people's eyes, where they're going to the national retinal screening. So there's a national program looking at people's retinas.
We're doing an episode on that.
Oh, right. Okay.
We got a message from a retinal technician or something along those lines. I've done the person serious misjustice, and I'll apologize to them when I come in. I can't remember his exact title.
Yeah.
But it's he was like, from looking into the eye, I can spot and see so many different health related challenges. So we're going to bring him in and have a chat. Anyway,
yeah.
You've teed it up really nicely for us. Good.
Yeah. So there's a really good national screening program for retinal screening, and that everyone with diabetes should be registered with this. So if someone's newly diagnosed with diabetes in clinic, one of the first things we would do would be make sure that they're registered with the retinal screening.
And for someone who has diabetes, what happens to the eyes?
So just at a really simple level, it's because you have high levels of circulating blood sugars in your blood vessels, and this leads to damage in the blood vessels, and that can cause damage in your eye. So we say that it has micro and macrovascular, and essentially what that means is it damages the small and the large vessels. And we also look at the kidneys, screening for complications in the kidneys, because it can lead to damage in your kidneys, and then the feet as well. So they would be the three common things that we check for in a diabetes clinic.
Chat to me about then pre-diabetes. So is that the testing phase of get yourself tested with your GP, and we catch it before it becomes diabetes? Yeah.
So pre-diabetes essentially means that you have a higher than normal blood sugar level when you test the bloods, but it's not in the diagnostic criteria for diabetes. So it's somewhere in between. So the blood test that we most commonly do is your hemoglobin A1C. HbA1c, yeah.
Love it, yeah.
Your glycated hemoglobin. And essentially over 48 or above is a diagnosis of diabetes, and then 42 to 48 or 42 to 47 is pre-diabetes. And so that's...
How often should one get their bloods done? I know that's a very whatever question. I do mine every 6 months for the crack, because I'm interested in it. Yeah. But to pick up stuff like this as people are getting older, should it be once a year on their birthday? Should it be once or twice a year? Or
I think it depends. I think if someone has diabetes, they'd be advising them to get their bloods checked every 6 months. I think if you're generally healthy and you don't have any other comorbidities, once a year is probably fine. But I think as we get older, it's probably more important to get them checked more regularly. So yeah, I think every 6 months to a year would probably be a ballpark answer to that. Yeah,
great, good. And with pre-diabetes, if you catch it early enough with a blood test and you're pre-diabetic, you can get that number down.
Yeah, definitely. And so there's currently the guidelines there's no pharmacological, so no drug treatment indicated for the management of pre-diabetes. Okay. So the treatment for pre-diabetes is lifestyle.
Go on.
Yeah.
Good.
And so there is a diabetes prevention program that everyone can be referred to, and that's kind of like an education program that's run by dietitians and diabetes.
We saw that the very last series of Operation Transformation. I'm nearly sure Sophie referred one of the leaders to that program. Mm-hmm. Look, and he was blown away by it, by the content and how good it was, and the knowledge that he got from it.
Yeah. So that's run by. So now with Sláinte Care and this chronic disease management program, and the move to move care away from the hospital and into the community, there's there's these new diabetes hubs that have been set up around the country, and these hubs are run by a consultant endocrinologist, but then they also have podiatry, dietitians and diabetes nurses working in these hubs as well. And so they run a lot of these education education sessions. They're predominantly run by dietitians and diabetes nurses. And so they're sessions that they run over, I think it's once a day for a number of weeks, and they have the option to do them online or in person. And people find them very beneficial, and I'd always refer someone that was diagnosed with diabetes and that wants to do these education programs in clinic to do them, and the waiting list is quite short as well.
And from a food perspective, like what changes should people be making? And I know I have a fair idea what you're going to say here now, but in the same boat, it's nice to hear it from a different voice. But if people are listening in who think, okay, look, I'm aging, I'm gaining weight, I'm gaining body fat, you know, I have a diet full of lots of processed foods.
Yeah,
I can see myself being at a high risk here. What do I change?
Yeah, so I guess there's no like one diet that's recommended. I suppose most of the principles in the HSE guidelines or in the UK guidelines align with what the Mediterranean diet essentially, which I guess, would be increasing your fiber, increasing your fatty fishes, your nuts, etc. I suppose what I would say is that it's probably when I would meet with someone in clinic and, you're giving them what the guidelines say, but in terms of exercise and food. But I guess I wouldn't expect someone to leave clinic and suddenly to start exercising 5 days a week and to suddenly completely change their diet. So, and I think when someone's diagnosed with diabetes, it can often be overwhelming, and you're talking about all these complications and how they have to watch out for all, what can happen. And sometimes I think that can be a lot to take in. So I think I would try and encourage people to take gradual steps.
Yeah, small steps.
Yeah,
but so from a food perspective, we're saying again, the Mediterranean diet, every guest we have in just keeps coming. It's like, okay, all right. So more fish, more nuts, more seeds, more fiber, more colour on the plate.
Yeah.
Sorry to all the farmers. Less red meat.
I think it's in moderation.
Meat and high blood sugar don't overly go together. No. It's more the
more carbohydrates. I think would be the major driver of high blood sugars. And I think for someone that has type 1 diabetes, when they have no insulin, they need to count their carbohydrates to match their insulin because their pancreas isn't working essentially. So, generally reducing processed carbohydrates would be the major thing. And then I think doing an education program, finding that time to actually take that and try and upskill and reset maybe how you're approaching things. But I also would say, I guess, I think weight and diabetes is complicated, and I wouldn't say it's as easy as, eat less and move more. And I think if that was the case, we wouldn't have rising rates of obesity or diabetes if it was that simple.
Yeah,
so I think it's
Donal O'Shea coming in later on for a chat all about that.
Oh, that's great. So I worked with Donal O'Shea.
Oh, so, yeah. He's in later. No, I think it's a really good point, and it's something on the show that we talk about time and time again, that it isn't as simple always as in and out in terms of calories, and it's and we try to upskill people and educate them around that. Because for a lot of people, there's so much more to it. I absolutely agree with that. But so what we're really saying to people from a diabetes perspective is Mediterranean diet. So more fish, more veg, less processed, starchy carbohydrates, more colour on the plate. And then from an exercise perspective, just do a bit more.
Just do
nothing too scary.
Yeah. And what I would say is what we'd often recommend is there's a really good resource called XWell or Exercise Well. It's a non-for-profit exercise program that essentially is designed for people living with chronic diseases, so for people with diabetes, COPD, etc. And it's a structured exercise program that's led by a medical team. There's about 40 different hubs around.
I've seen this as well. It's brilliant. It's really good. Yeah, no, it is. It's excellent. Yeah.
And sometimes, I guess people just don't know where to start with exercise or with the gym.
Yep.
And I've gotten really good. I'm not affiliated with it anyway, but I've just gotten really good feedback from people coming back to clinic that have been to this as well.
In terms of treatments then, so type 1, it's counting your carbohydrate, it's matching like for like. For type 2?
So for type 2, I think it's a really great time to be working in diabetes because we have so many new treatments that we didn't have before. So So I think we still have, I think the first line treatment is still metformin, but now we have obviously the newer medications, so the GLP-1 medications such as Ozempic, and then we also have the SGLT2s, so things like dapagliflozin or empagliflozin, which are other diabetes medications. And I think we probably would use those sooner now than before, depending on, you know, what the main issue is. So if someone has heart failure and diabetes, we would probably go with one of those medications, like an SGLT2, because they've been proven to work in heart failure and actually are used in heart failure treatment now as well for people that don't have diabetes. So I think we have a lot more options now in terms of medications to treat diabetes that weren't there, you know, 10 years ago. But I would say, you know, Ozempic and GLP-1s were first designed in diabetes, and essentially, you know, they were treating diabetes. We have a lot of experience with using them in diabetes, you know, as well. And there are newer medications coming down the line. So now we obviously have tirzepatide, and there's retatrutide that's in clinical trials. That's a triple therapy. So Ozempic is a single agent, and then tirzepatide or Mounjaro is double, and then we have triples in studies. Wow. So there's going to be, you know, they're here to stay essentially.
So it's fair to say it's an exciting time to be in the fields that you're in.
Yeah, definitely.
And if people are listening in who may be concerned that they have prediabetes or type 1 or type 2, I would get reassurance from listening to what we're saying so far.
Yeah, so what I would say is that, like, there's, while diabetes is mostly a lifelong condition, you know, a lot of people live long and healthy lives with diabetes, and I think the important part is, you know, controlling the blood sugars as best that you can and controlling the other risk factors as best that you can. So I think the most important thing is to take that action, is to, you know, to go to your GP, to get the diagnosis, to start treatment, and to engage as best as you can, because I think the danger with diabetes is what we always say is that, you know, high blood sugars are not really dangerous in the short term. It's more in the long term, and, you know, 10, 15 years from when you're diagnosed. So it's more about preventing the complications and allowing you to live a healthier kind of life in the next 20 years or so.
Chat to me about Desmond and Discover and who can take part.
So anyone that's diagnosed with diabetes can take part in that. So you don't have to have a medical card or a GP visit card to take part in that. So you do have to have, if you want to take part in the chronic disease management program, which is a 6-month visit with your GP, you have to have a medical card or a GP visit card. But anyone can be referred to Desmond or Discover who has been diagnosed with diabetes. You don't need to have a card for that.
So they're diabetes programs?
They're diabetes programs. So they're kind of like structured education programs for people with type 2 diabetes. And an equivalent to that in type 1 diabetes would be DAPHNE. So it stands for Dose Adjustment for Normal Eating. And that's more about a self-management program and teaching people how to count carbohydrates and give insulin in response to that. So that's a really beneficial program as well. And then I know Diabetes Ireland also run an education program called CODE as well, which is an education program for people with type 2 diabetes. So there's a lot of options out there for people that have, you know, you don't have to be recently diagnosed, so you can be diagnosed with diabetes anytime, and still diabetes is a long-term, lifelong condition. And so I guess as your diabetes team, we're there to help you and to guide you along that journey and to kind of offer the resources that are available. And I think that has changed a lot in the last few years. So I think, yeah, as you said, like, there's a lot of resources out there. So Diabetes Ireland, UGP and HSC as well. And then there's the Chronic Disease Management Programme and the hubs locally as well.
Amazing. Dr. Seán Maher, thank you so much for coming in. 25 minutes on diabetes. Who knew?
Great. Thanks for having me.
Look, we're delighted to have you in a really important topic and great content, so much appreciated. Folks, I really hope you enjoyed today's episode of Real Health with me, a very hoarse Karl Henry. Don't forget to rate and review. You can let us know at Karl Henry PT on Instagram, Real Health at independent.ie, and on the Irish Independent website. And we'll see you next week for more Real Health. Slán go fóill.